The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everyone, my name is Mike Lauria, and welcome to the Flightbridge Ed MDCast. I am an emergency EMS and flight physician currently in critical care fellowship, and the point of this podcast is to give you some very valuable take-home points and a mental model that you can apply at the bedside when you're taking care of some of these critically ill patients in transport. Today we're going to talk about salicylate intoxication. Eric did a phenomenal podcast on this back in March, discussing in great detail the pathophysiology of salicylate intoxication and some of the nuances of management. And indeed, the management of these patients is very nuanced. But what I'm going to go through today is how we can boil that down to a handful of things that you can hopefully remember at the bedside when you're treating one of these patients. So the thing to keep in mind is, as salicylate levels rise, and sort of get, general numbers about salicylate level of 15 to 30 is essentially therapeutic, and I would say normal. Above 40 is where we start to get concerned, and above 80 would be considered really, really bad. Now, of course, the number that we're measuring is really a surrogate for what we're really worried about. What I'm really worried about, and this is a really important point, is how much of that salicylate is unionized, is not ionized, because the unionized form of salicylate that can actually sneak across cell membranes and get into the cells and do all kinds of damage, essentially unhinge the process of cellular respiration. So based upon that, the thing that I am particularly worried about, or the syndrome that I'm very concerned about seeing, is what some people have referred to as this salicylate spiral of death. And basically what happens is, normally when someone experiences salicylate intoxication, we see in the classic book teaching is, in fact, that they will have an intrinsic respiratory alkalosis. So the salicylate will, in and of itself, stimulate the respiratory centers to breathe faster. So that's the classic book teaching. As it turns out, because you can also have kidney injury and other things going on, you can have concurrent processes. You can have a respiratory alkalosis with a metabolic acidosis. But I think the point here is that respiratory alkalosis is, in a sense, a little bit protective, because the more alkalotic the blood is, the more of that salicylate is actually ionized, and the less likely it is to actually get into cells. And we talk about that spiral of death that I mentioned. What happens is, as more and more salicylate gets into the brain, it causes altered mental status. People start to get kind of sleepy. The sleepier they get, the less they breathe. As their minute ventilation drops, so does their pH. It starts to go down. As their pH goes down, more and more of that salicylate becomes unionized, sneaks into cells, in particular sneaks into the brain, makes people even sleepier, drives their minute ventilation even lower. They're breathing less and less. They become more acidotic, more salicylate gets into the cells, and it's this vicious downward cycle. And that is the thing that we're trying to really, really avoid, especially in this circumstance that I'm talking about, in the relatively short-term, relatively acute period of transferring this patient from an outside ED or an outside ICU to a tertiary or quaternary care center, and also specifically in the setting of an acute intoxication, not necessarily talking about chronic intoxications here, a little old lady or little old man who's been taking a little bit too much aspirin for many days or weeks, talking about a one-time large quantity ingestion. When I think about avoiding that spiral of death, I keep two things in my mind. And this is my mantra, and this is, I think, the mantra you should have. Defend the brain, get the salicylate out. Defend the brain, and get the salicylate out of the body or eliminate it from the body. So how do we do that? Well, in terms of defending the brain, the usual things apply. Make sure that people are volume resuscitated, keep their hemodynamics in a state where their brain is getting perfused. Make sure that if they're no longer protecting their airway or they're no longer defending their CO2, that we help them with that. They may need to be intubated, although by and large, we try to avoid it at all costs and let patients compensate for themselves. A patient can maintain their own minute ventilation much better than we can, even with the best ventilator. So keep that in mind. The second thing that we're going to do is really try to keep that salicylate in its ionized form by essentially alkalinizing the blood. And how we're going to do that is we are going to, we can give them some bicarb, a couple of amps, I think, to start out is fine if they haven't already gotten it in the outside ED or ICU. And we're going to shoot for a pH of 7.5 to 7.55, right around there. How we're going to continue to do that after someone's already had the couple amps of bicarb is something we can do in transport as transport providers. And the way we actually do that is we take a liter of D5, we pull 150 cc's out and put in 3 amps of bicarb. You can start out running that like 150, 200 cc's an hour, and you can keep on going with that. As it turns out, that mixture gives you about 150 milliequivalents of sodium and 150 milliequivalents of bicarb in a liter, which is essentially isotonic, so it works pretty well as both the resuscitation fluid and to help alkalinize their urine. That's also important that they get plenty of fluid, because often a lot of these patients have had significant nausea and vomiting and haven't been eating and drinking well before they come in. But running that bicarb in and keeping their pH up, you can check using point of care venous blood gases, their pH every half hour to an hour in transport. In the ICU or the hospital, we'll do it every 2 to 4-ish hours, especially in the setting of an acute intoxication. And if their pH is below target, you can go ahead and increase that bicarb drip by about 100 to 200 cc's an hour, shooting for that 7.50 to 7.55 range. The other reason why I like using the D5 bicarb solution is that what you can get under these circumstances is what's called neuroglycopenia. So normally the glucose in the CSF is a little bit lower than the serum glucose, but under these circumstances, the brain, in a sense that it's not making enough ATP because the salicylate has completely thrown a wrench in your ATP generation mechanism, right? Your cellular respiration. And in response to that, it really begins to chew through glucose. It increases glycolysis, and therefore the CSF and levels of glucose in the brain can be way lower than those in the serum, abnormally lower than the serum. And in fact, you can have a normal blood glucose of 85, 90, 100, something like that. And the amount of glucose in the CSF in the brain could be dangerously low. So we'll generally shoot for keeping it higher, the blood glucose higher than like 100 to 120. And with an infusion of D5 at that rate, you'll certainly be able to do that. So it's kind of, it's defending the brain essentially in 2 ways. So that's defend the brain. The other piece of the equation is eliminate the problem, getting that bicarb out of the body. And how we do that is by peeing it out. So essentially what we were trying to do is we were trying to get the serum pH 7.5 to 7.55. We're really trying to get the urine pH even higher than that, like 7.5, closer to 8.0 if possible, is generally been the target. And of course, we're going to do that by increasing that bicarb infusion if they're not at goal, if they're not getting close to or above 8 for a urine pH. In fact, there are some institutions that determine the titration of the bicarb or increase the bicarb, not necessarily based on the serum pH so much as the urine pH. That encourages you to, if the urine pH is low, you go ahead and increase the drip until the serum pH is about 7.55. There's other things that we can do as transport providers to make sure that we're optimizing the alkalinization of the urine. One of those things, interestingly enough, is making sure that their potassium is actually repleted very, very well. So essentially normal to a little higher than we normally would. In most ICUs, we'll shoot for 4. That's not the most evidence-based practice, but most guidelines in most ICUs would say replete patients' potassium above 4. Under these circumstances, we really want to keep it above 4 or 4.5. And the reason is if you're hypokalemic, you will actually your tubules will reabsorb potassium and they will dump out hydrogen ions, which actually works against all of that alkalization we're trying to do. So if we keep the serum potassium level above or at normal, so above 4 to 4.5, then what we're trying to do is mitigate that effect of the kidneys absorbing potassium and dumping out hydrogen ions into the urine. So keeping their potassium up and making sure their urine is alkalized. This is also something we can check actually in transport, because these patients should have Foleys, and especially if they're altered, it is reasonable to put a Foley in one of these patients. And as urine is coming out, we are very carefully watching the urine pH. And you can actually take some of the fresh urine. So when you get to the bedside, dump out the canister or the container, and then as that fresh urine is coming out, or from the sampling port, even better, on the line, go ahead and take some of that urine, and you can test it with you can get some dip strips from the outside hospital, and you can dip the urine to look at the pH. Technically speaking, I can't formally recommend this, and I'm sure the CLIA people wouldn't get up in arms, but the cartridges for the iStat, actually the blood gas cartridges, they just sense a pH of any fluid, right? That blue test fluid that you use, blood, urine, essentially any fluid, it could test the pH. So theoretically, and I can't formally recommend this, but you could use an iStat to check urine pH as well. Either way, you can monitor it, and it may be helpful to report that, especially if things are not going so well, trying to measure that and then report it to the receiving facility. A couple of other notes. I really mentioned that we really want to try and avoid intubating these patients if at all possible. Let them compensate for themselves. Let them blow off as much CO2 as possible and maintain that respiratory alkalosis. However, if they're not maintaining their CO2 on their own, if you see them getting sleepier, if you're seeing their PCO2 start to rise on the venous blood gas, that may be a sign that you need to intubate them to take over, especially as they're getting more altered and or not maintaining their airway. The other thing I would mention is that dialysis is actually really effective for these patients. So, and I would say that usually the vast majority of the time, I haven't seen this very much, but the vast majority of the time, the sending physician coordinates that very well with the receiving center and would not send them to a center without dialysis capability. However, if you happen to know that the facility you're going to or your destination facility does not have dialysis for some reason, it may be worthwhile at least mentioning that to the sending provider so they're aware. They likely have already worked it out, but if you have concerns, it would definitely be worthwhile to at least ask the question. So, remember, with salicylate intoxication, the most dangerous thing is not sliding into that spiral of death where they're becoming sleepier, more acidotic, increasing the amount of unionized salicylate that's getting into their blood and making them worse. In order to break that cycle, we have to defend the brain and eliminate the problem. Defend the brain and eliminate that salicylate. Defending the brain, we're going to make sure we do all the normal supportive critical care stuff very, very well. We're going to make sure that we begin to alkalinize the serum by giving them a couple bicarb amps if they haven't had it already, but more importantly, starting that drip of D5 with 150 milliequivalents of sodium bicarb in it, and continuing to make sure that their blood glucose stays above 100 to 120-ish. And if they become more altered, it would not be unreasonable to give them a little more dextrose. The other thing is eliminating it from the body. Make sure that we try and shoot for that urine pH of 8. You can test that urine with urine dip strips or other ways if possible before you leave, or if you have the time and it's a long, say, fixed wing flight, you can test it en route and really shoot to drive that pH up to 8. Also making sure on the way that we're not working against ourselves, that we're making sure their potassium is above 4 to 4.5 to optimize the alkalization of the urine. A couple quick notes. As with many toxicology things. There is not the most robust literature, as there is under certain circumstances where we have tons of RTCs and lots of good data. Data and the recommendations for salicylate intoxication and other toxic processes like acetaminophen is actually reasonably good, and I've included a lot of the resources that I use to develop some of these thoughts and guidelines in the show notes for this particular podcast. I'll make sure that the references are available. By all means, just like in anything else, go through, read on your own, and see how you can incorporate and develop it into your own practice at the bedside. Thank you guys so much for your time and attention. Take care and fly safe out there.
This has been a production of the Flight Bridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.